Oh, le choix de traitement. Donc, en 2012, ça veut dire que j'avais à peu près 53 ans.
J'avais le choix entre la surveillance active, la radiothérapie et la chirurgie.
On a échangé quelques minutes seulement avec mon urologue.
Les urologues et les onco-urologues possèdent tellement d'informations qui peuvent effectivement répondre à toutes les questions.
En plus d'en parler à mon urologue, en plus d'en parler, j'en ai parlé à mon médecin généraliste, il a amené ses collègues. J'en ai parlé avec ses collègues. Et évidemment, la documentation que j'ai reçue était très complète.
Vous prendrez la décision qui vous revient, après m'en avoir parlé, bien sûr. Évidemment, il demeure l'expert, mais c'est quand même ma vie.
Et dans ma tête à moi, je n'étais pas prêt à me faire opérer pour le cancer. Quand on m'a dit qu'il y avait des alternatives, je pouvais avoir un suivi actif qu'on appelle.
Si j'avais choisi la surveillance active, ben ce serait ma sœur m'aurait tué. Mais en même temps, la surveillance active pour un gars de mon âge, j'avais 48 ans à l'époque, c'est un peu, si on traduit ça en termes laïques, c'est bon, on attend pour voir si ça va empirer.
Évidemment, avec l'aide d'un onco-urologue, éliminer certaines formes d'intervention pour en arriver à celle que je mentionnais tout à l'heure, une prostatectomie radicale.
J'ai choisi l'option qui avait le moins d'impact sur ma performance érectile. Bon.
Quand il y a de la progression au niveau du cancer, tu décides si tu veux faire enlever la prostate. Mais tu peux décider aussi de ne pas faire enlever la prostate et de faire la chimiothérapie, la radiothérapie.
J'ai longtemps hésité entre les deux, mais c'est quand j'ai appris que suite à une radiothérapie, s'il y a un retour du cancer, mais on ne peut pas opérer. Fait que j'ai pris la chirurgie, mais si jamais il y a un retour du cancer, il y aura toujours la possibilité d'autres traitements par la suite.
Moi, j'ai choisi le suivi actif et l'opération.
On a choisi, avec l'aide de mon onco-urologue, une forme d'intervention qui est une radiothérapie.
À quelque part, il y avait une forme de soulagement le fait d'être pris en charge, justement, par le système. Si vous avez des doutes, il y a des ressources qui sont disponibles, entre autres Procure, qui sont là pour justement centraliser l'information.
Où on peut appeler n'importe quand, de n'importe où, pour avoir des réponses à ces questions. Dans un très court laps de temps, quelqu'un va vous rappeler.
Alors, good evening, ladies and gentlemen. Welcome to Procure en Parle. For those who are joining us for the very first time, Procure is a not-for-profit organization like the Canadian Cancer Society, except we are entirely dedicated to prostate cancer. And since information is the first remedy, Procure offers a monthly webinar on various topics to learn all about the disease which affects 12 men every day here in Quebec. And you can certainly fight in style for all men diagnosed with prostate cancer by joining the Bovember awareness campaign and activities, and by wearing the beautiful 2020 bow tie edition. And if you still don't have it, well, all you have to do is go on our website, procure.ca. Now, tonight's topic is to demystify advanced prostate cancer, its treatment, new therapies with Dr. Armen Aprikian. A leading urologic oncologist and researcher, Dr. Aprikian is also professor of surgery, vice chair of the Department of Oncology at McGill University, medical director of the Cedars Cancer Center at the MUCH, clinical lead for the Rossi Cancer Network, and vice president of the Canadian Urological Association. Now, he will be answering questions we already received from patients and your questions as well. You can ask your questions by using the QA button at the bottom of your screen. Please do not use the chat, just use the QA button. The only thing that we ask you is to keep your questions short, if at all possible. And of course, advanced prostate cancer questions will be prioritized. Now, before starting, we would like to thank all of our donors from the bottom of our heart, our partners, Cedars Cancer Foundation and l'Association des Urologues du Québec, And the official presenters of this webinar, AstraZeneca and Merck, laboratories which, among others, are involved in the treatment of more aggressive and more advanced prostate cancer. Now, this being said, thank you, Dr. Aprikian, for accepting our invitation. And without any further delay, I will give the floor up to you.
Thank you. Thank you very much, Marie-Christine. And I want to thank the entire staff at Procure for organizing this. This is an organization that's very dear to my heart. And it does tremendous work to help patients and their families navigate their prostate cancer trajectory. And I'm very pleased to be here to answer as many questions as I can about a very evolving topic. And there's a lot of good news in prostate cancer, especially in the area when the cancer is advanced. So I'm prepared to answer as many questions as I can. Thank you, Marie-Christine.
Thank you, Dr. Aprikian. We're going to start with 4 general questions before going into details with more types of advanced prostate cancer. And the first question that we rarely ask, but that we should ask, is how does prostate cancer form and develop? And why does the risk increase with age?
So that's an excellent question. First of all, there's nothing unique about prostate cancer with respect to it developing as men get older. This is very common in just about every cancer. As the people age, men and women, we accumulate genetic defects, mutations in some of the genes in particular tissues. We get exposed to a variety of carcinogens, and over time, these accumulate, and the normal behavior of our cells start to change and develop into cancers. So that's not unique for prostate cancer. How does prostate cancer develop? That is an excellent question. We still have many questions in this area that we cannot answer. We do have an idea that for prostate cancer to thrive, it requires the male hormone testosterone. And that's why much of the treatment for cancer of the prostate when it's advancing is to remove as much testosterone as possible because then the cancer cells suffer and many of them die.
Dr. Aprikian, as part of your patients, have you seen any patients with advanced prostate cancer being cured, or is it something that we control?
So it depends how we define advanced prostate cancer. Certain cancers of the prostate where the cancer has spread outside the prostate but has not reached other organs like the bones or the liver or the lungs, yes, there's still a decent chance that such cancer cases can be cured. When cancer reaches organs like the bone or the liver or the lung, then the chance of cure is extremely rare, although not impossible. But the good news is that we can control the disease. So we can put it asleep, and when it starts to wake up, we can slow it down so that the impact of the disease on the patient is not as noticeable. So that's quite common these days.
And what is the rate of men having more advanced prostate cancer at time of diagnosis in your practice?
Fortunately, this is not as common because of the PSA test. When men get their PSA test routinely, then the chance that they later develop advanced prostate cancer without knowing about it is quite rare. And that's the whole point of doing the PSA test, so that the cancers can be identified early. Yes, sometimes when PSA tests are not done, then we do see some men who present with pain in their back or bleeding when they urinate, and then we identify and realize that there's a cancer that is more advanced. Fortunately, this is not as common. During the recent pandemic, there was some delays in certain tests to be done, and men perhaps were not able to access their family doctors to do certain tests. So it's possible that during the pandemic, there is a slight increase in a bit more advanced prostate cancers. But if the PSA test is done routinely, that should be a rare thing that we find cancers that present in an advanced stage.
And can a man have advanced prostate cancer without any symptoms and feeling just fine?
This is possible. Again, some men, unfortunately, their first PSA test may be quite high, and they feel fine. And we do tests, and we find small areas of cancer that has spread, too small for them to have noticed, but big enough that when we do a scan, we see them. So this is possible.
Okay. Let's talk a little bit about standard hormone therapy before we go further down into treatments. What is the recurrence rate in general after standard treatment? And how do we know where that recurrence is exactly?
Again, excellent point. So the first thing, just to summarize, is for prostate cancer, similar to breast cancer, in one sense, there is some good news there, because we know that one of the major nutritious elements for the cancer is the testosterone, so the hormones. Many other cancers, we don't know that. So for pancreatic cancer, colon cancer, lung cancer, we don't have that knowledge. So in prostate cancer, we know that one of the big issues is testosterone, the male hormone, and we can attack it, we can deprive it, we can decrease it, and this gives us a very big impact against the cancer. So on that front, we're a bit fortunate. Now, if the cancer is advanced, meaning there's cancer in the bones or in the liver, hormone treatment is very effective, but not a cure. And after a few years of keeping the testosterone very low, unfortunately, the cancer starts to learn and starts to wake up and becomes what we call hormone resistant or castration resistant. Now, the first sign of that is the PSA test that slowly starts to go up. Usually when we start hormone treatment for advanced prostate cancer, the PSA can go from 100 or even 1,000 down to 0. And that's excellent. And we can keep it there for quite some time. However, almost always the PSA will start to go up again. And that's usually the first sign, well before the patient feels anything. And it gives the doctor enough time to do some tests to find out where this cancer is. Is it in the bones again? Is it somewhere new? And that's where we do a variety of scans, bone scans, CT scans, MRIs. And nowadays we have newer types of scans called PSMA scans, which is a form of nuclear medicine studies, to be able to identify where the cancer is recurring.
Okay, this is good. What is the percentage of it? Let's talk about the non-metastatic castration-resistant prostate cancer here. What is the percentage of men who will develop resistance to standard hormone therapy?
Well, again, almost all, because hormone therapy, the standard, or castration as we call it, doesn't eliminate every cancer cell. It eliminates many of them, but there's always a small proportion that is put asleep and then eventually wakes up, oftentimes years later. So just about every man, this cancer will wake up. Now, when we first see the PSA go up, so the PSA can be 0, 0, 0, and after a few years, it starts to go up to 2, and then 4, and then 10. And then we do scans. Sometimes we don't see anything. And all we have is the PSA count that is telling us the cancer is waking up, but the scans don't show anything and the patient feels well. Well, in the past, we used to just wait. We used to wait and see until something was visible on a scan to be able to change treatment. The good news today is that we have newer medication, oral medication, tablets, that can be added to the standard hormone treatment that men receive to make that PSA test go down, but more importantly, can prolong the time there is something that is visible on a scan, metastases, and as well as prolong life, meaning decrease the chance of dying or pushing back the time it takes until the cancer causes death. So that's relatively new. And we have several drugs that are available, which are very well tolerated for that exact setting where we don't see metastases, but the standard hormone treatment is no longer enough.
I have a question for you, Dr. Aprikian. My urologist prescribed apalutamide. By the way, here we're talking about enzalutamide, apalutamide, and darolutamide. Those are the three agents, new agents to delay metastasis.
Yes. So those are three drugs in the same family. They have small differences between them, but together they achieve the same objective, and that is they delay the time for metastases to develop and delay the time for the cancer to cause death. Okay.
So this patient here says he's being prescribed one of these agents. He's wondering, why does he have to stay on his standard therapy? Why can't he just stop the injections?
Yeah, that's a fantastic question. And many of us, even the clinicians, ask this question. However, we don't know if it's safe to stop the standard hormone treatment because when the studies were done to show that a drug like apalutamide, for example, improved the survival, it was done in addition to standard hormone treatment. So in order to determine if it's safe to stop the injections and just take apalutamide, we would have to do another study where that was tested. So right now, since we're not sure and we're dealing with a cancer that is potentially lethal, we don't take the chances. Having said that, there's not much gain except for cost to stopping the injection. It's not like the side effects or your quality of life will improve by stopping the injections if you're still taking the apalutamide, because the impact on the testosterone will be the same.
Okay, so when we're talking about these three new agents, we're talking about the same type of side effects as standard hormone therapy. Is that correct?
So the standard hormone treatment therapy, which reduces the testosterone to very low levels, and many men who are on hormone therapy will tell you what they are. They're like the traditional hot flashes that men get that are similar to what women feel when they go through menopause. They get tired, they lose their muscle strength because, again, the testosterone has been decreased, and men need the testosterone to be as vibrant as possible. They lose their libido or their sexual appetite, and they develop erectile dysfunction. So these are some of the side effects that come with standard hormone treatment. When we add to standard hormone treatment drugs like enzalutamide, apalutamide, darolutamide, the main side effect is usually a bit more fatigue. Not terrible fatigue, but a bit more than what they were used to with the standard hormone treatment. There are other potential side effects like high blood pressure. Then each drug has its own small differences, but these are not major side effects and usually not enough to stop treatment in someone in whom the drug is needed.
All right. How long can they delay metastasis?
So they can delay metastasis by 1.5 to 2 years. So that's in people in whom the drug is working. So this is a very significant. Plus, the drug is not for everyone. So for example, the main group in which these drugs are the most helpful is when the PSA count is rising, but rising fast. And what we mean by fast is that the PSA count is doubling 2, 4, 8, 16 every 6 months or so. That would be considered a rapid rising PSA count. And it's in those types of patients in whom these drugs work the best. In a person whose PSA count is rising, but rising very slowly, 2 and then 3 and then 4 every 3 or 6 months, we believe that the time that that patient actually develops metastases is so far down the road, it doesn't warrant the side effects for taking these drugs at the moment.
Okay. One question here. What can I do to protect my bones? And will vitamin D help? In other words, you know, I'm on these drugs, I'm on hormone therapy. I want to delay metastasis as much as I can. What can I do to help out, particularly my bones?
Yeah, so that's an excellent point. So when we lower testosterone in men, we create osteoporosis. The bones in a man become more brittle. They decrease their density, bone density, and they are at risk for having a fracture if they fall down, for example. So this is this is well known, and that's why any man who is prescribed a traditional hormone treatment where the testosterone level is being decreased, the doctor has to also add vitamin D and calcium to that prescription to try and maintain the bone density as much as possible. That's number one. Number two, is very, very important that the man remains active. And the activity could be something as simple as 30 minutes to an hour of walking, simple walking a day, or if they're used to being more active, well, to maintain their activity, exercise. And these help keep the bones and also the muscle strength as active as possible while the testosterone is being kept low. However, in some men who are let's say older, 75 or older, or have other medical issues, the doctor can order a bone density test to determine what is the risk of the hormone treatment creating very severe osteoporosis, where the risk of fracture can be quite high. And in those types of people where a bone density test can show that the osteoporosis is going to be severe, there are drugs available like denosumab injections once a month or once every few months, or other drugs that can help maintain the bone density while they're on hormone treatment.
Okay. Thank you. Let's go to metastatic prostate cancer, but let's do both. Is there a difference in terms of treatment of a metastatic prostate cancer at diagnosis versus one that has become castration-resistant prostate cancer with metastasis?
So again, when cancer is metastatic, whether the cancer presented right away as metastatic or the cancer developed metastases later while the cancer was progressing, the main treatment is the standard hormone treatment, like the injections that men receive every 3, 4, 6 months. This is sort of what we call the backbone. Now, in the last couple of years, we've learned that we can improve the outcomes of patients who have cancer in their bones from the beginning by adding to the standard hormone treatment some of these new drugs, and another one which is called abiraterone or Zytiga is another one that can be added to the traditional injections that men receive for their hormone treatment, and this maximizes the hormone therapy and again prolongs life. Now, when the cancer is metastatic and becomes castration resistant, meaning the standard hormone treatment is not working anymore, and if they've never seen or received some of the newer drugs that we talked about, then we can start those new drugs. If, however, they were exposed to the new drugs already and the cancer developed into what we call castration resistant with metastases, then the next step usually is chemotherapy. And chemotherapy is very well tolerated, even though it sounds bad. And it's true that chemotherapy is delivered in the hospital, where patients come once every 3 weeks for an injection, and usually between 6 to 10 injections, but it's quite effective. So again, we start with standard hormone treatment. We add some of the newer hormonal drugs like abiraterone, enzalutamide, apalutamide, darolutamide, one of these. And then when it's no longer working, we move on usually to chemotherapy. There are other treatments available, and maybe we'll get into that later for specific cases, but this is the normal sequence.
Okay. Can any of these drugs or chemotherapy make the tumors go away, melt away? That is a frequent question that we get.
Yeah, so we've seen remarkable cases where on scans there are lots of metastases, and then very remarkably, with the addition of some of these new treatments, we see the cancer, as you mentioned, melt away, where the scans look almost normal. And more importantly, we rely a lot on how the PSA count drops, and that's usually a very good predictor. When we see a PSA go from 1,000 down to 100, and then from 100 down to 50, and then from 50 to 0, usually when we do scans, we also see remarkable reduction and even disappearance of many of the metastatic sites. So that can happen. Unfortunately, a while later, and that's very hard to predict, whether it's months or a couple of years later, some of the spots will reappear. And that usually coincides with the PSA count starting to go back up again.
All right. There's a question from a patient. I have one metastasis in my lymph node. I'm on Zytiga and Zoladex at this time. The size of the tumor has not changed. There's nothing that we see on bone scans. Now my PSA is going up very slowly. You know, it's not doubling or anything. It's just going up very, very slowly. And I was wondering, is there a way to get rid of that tumor in my lymph node? Can we operate? Can we irradiate it? Can we do something about it?
So the answer is yes, we certainly can. The question is it the right thing to do? So without knowing more about this particular case, in people who have just one area of a metastasis, particularly, let's say, in a lymph node, and on all the scans, we see nothing more, and the patient is receiving the best hormone treatment, as is demonstrated by this case, then yes, we can add radiation treatment to that specific area, as long as that area is not attached to some other important part of the body where we don't want to damage. But yes, we can target that and apply radiation treatment. This can be done in a lymph node. It could be done if it's in the bone. It could be done if it's in the lung. So yes, we can target these spots as long as they're small and few in number, to try to delay the time it takes for them to grow. When we have multiple, then it's not so simple. And doing surgery to remove, whether it's a lymph node or a metastasis, usually is not a good idea because the risks outweigh the benefit.
All right. We're getting into a little bit more advanced prostate cancer here. So some of the questions are, they also include survival years and so on and so forth. Let's start here with, I received chemo with docetaxel, then cabazitaxel, and back on docetaxel. Now I'm on radium-223. Once these treatments are completed, what are my alternatives?
So again, without knowing what else treatments were delivered in the past, assuming that this person had received some of the other drugs, the abiraterone, enzalutamide. If they haven't, then certainly that can be tried. If they have, then the next best thing would be to find out if the patient is eligible for a study. There are always studies available of newer drugs that have yet been approved, but patients can have access to something that may be quite unique for them. So that's one possibility, to ask their doctor if there are any studies, research studies, testing new drugs that could be used, which would be quite helpful. Number one. Number two, again, based on what the scans show, if the scans don't show a lot of disease in only one area, we can do something to that one area with radiation, for example. There are newer treatments that have just been identified and not yet available, but soon will be available. These are new drugs where the patient's cancer is sampled, a biopsy, for example, and then the genetic makeup of the cancer is studied. And if they carry a certain type of a mutation in the gene, then they can have a particular drug that targets that particular genetic defect. This is what we mean by precision medicine, precision oncology, is the ability to sample the person's cancer, sequence it, find out what the genetic defects are, and then target that with any existing drugs that can target that particular genetic change. So that's very exciting, actually. And there is a particular drug that was just shown to show benefit called olaparib.
I was going to ask that question because it was asked already. Can you please give us a little bit more information about olaparib?
Yeah, so olaparib is quite exciting, but it's really for the minority of people. So this is a drug that targets, that helps kill cancers that rely on a certain genetic mutation. And unfortunately, most prostate cancers don't carry that mutation, but some do. So if a person's cancer has that mutation, then olaparib can be quite helpful. And this was proven to be beneficial, proven to prolong life in a big study that was published last year. So, and this will slowly start to make through the governmental regulations to a point where patients could have access to it. However, if the person's cancer doesn't carry that mutation, well, then olaparib is not very useful in that setting, and the patient would not qualify to get it. What is new that is also quite exciting is PSMA-based treatment. As we discussed earlier, there are scans that can be done to see where prostate cancer is based on a particular molecule that the cancer has on its surface, and with antibodies that direct against those elements on the cancer cell. And if you put a little flare on it and you do a scan, you can see where the flares light up. This is called a PSMA scan. The PSMA scan is very helpful in trying to identify small amounts of cancer that are not traditionally visible. And PSMA scanning is used for detecting where cancer has spread to, and the scans have been used in many centers across the country, but in a research setting. The PSMA scan is available in a private setting, and you can ask your doctor if a PSMA scan is helpful, and then they can help you obtain such a scan. However, the PSMA molecule, since there are antibodies that can target where the cancer cells are, it makes natural sense that instead of just putting a flare so that we can see it, we can tag it with something that'll kill the cancer cell. So that way we are delivering mini bombs to where these cancer cells are hiding using the PSMA antibody. And there are a lot of exciting studies going on right now where people get an injection, intravenous injection of a PSMA molecule that's tagged with some form of radioactivity to kill cancer, and then those antibodies go and look for where the cancer is. So I predict in the next couple of years we'll be able to add yet another new treatment. This one will be based on radioactivity that's injected, for which it goes around looking for PSMA prostate cancer cells.
Is this the lutetium
Yes.
treatment? Okay, because we had a question about that. Is that clinical? I understand it's in a protocol setting right now. Do you need technology, special technology, to actually have access to this type of treatment, if I can say, or scan, if I can say, or can patient actually, you know, based on where they are, have access to this type of technology?
Yeah, so it does require a specialized nuclear medicine department. Most of the major hospitals in the province have such facilities, so it's not that restricted. However, those facilities have to be part of a protocol to deliver the lutetium substance. It's not complicated, but it does require a nuclear medicine department that is participating in such a study. There are a few in the province, and the doctor of the patient can certainly refer the patient to the nearby facility. But it's still a research protocol, so it's not for everybody.
All right. There is a question about immunotherapy and whether or not it works for prostate cancer. Is there hope?
So at the moment, it's a little bit disappointing for immunotherapy. Immunotherapy is working actually very, very well for many other cancers, but not for other cancers like prostate. However, you know, we haven't given up on it. It's still being studied in a variety of settings, but at the moment, it hasn't reached the point where it would be used in clinical practice.
All right. Now, again, there's questions from patients right now. Some of them are on standard hormone therapy, and their PSA is going up. It's slowly going up, and their urologist basically said, you know what, at this time, let's not do anything. Let's continue. Let's wait. And I'm not ready to put you on any other drugs at this time. So the question is, would it make sense to change hormone therapy, or would I still see the same results with my PSA?
So this is understandably quite a frustrating situation where the patient sees the PSA slowly going up and therefore understands the cancer is slowly waking up. And yet the doctor is trying to reassure the patient that this rise in PSA is not dangerous and we can wait. So it's understandable that this creates some confusion and patients want to see what else they can do. However, it is true that a slowly rising PSA is not dangerous, does not require immediate action. The doctor does need to make sure there's no visible cancer on any scans. And if the scans are clean and the PSA is rising slowly, there's no need to panic and no need to change treatment. Now, changing the hormone treatment rarely helps unless the hormone treatment is not doing what it's supposed to. The hormonal treatment, the injections that we talk about, the ones that people get every 3, 4, 6 months, the goal is to decrease the testosterone level. And usually the doctors measure the testosterone level every time there's a PSA test measured also. So if the testosterone is actually quite low, let's say it's under 1, that means the hormone treatment, the injection is doing what we want of it. And I don't see much point in changing the injection because by doing that, the PSA normally doesn't go back down. However, sometimes when we measure the testosterone, we realize that testosterone is actually not under 1. It's actually 2 or 3. That's too high. So when the PSA is rising and the testosterone is not under 1, that means the injection is the problem. And there it's worth considering changing the injection to a different one to make sure the testosterone goes back down under 1. And oftentimes by doing that, the PSA will go back down.
When you're in front of a patient with a very, very high PSA, like over 100 or whatsoever, and you start a treatment, how fast can that PSA drop to a level that will mean that really the cancer is under control?
Again, the goal is to take that PSA to zero. And sometimes the PSA goes to zero right away, like within a few weeks, it goes right down to zero. Other times it takes a few months before it goes down to zero. But the goal is to get it to zero. And the rapidity with which the PSA goes to zero usually means the longer it will take for the cancer to resist the hormone treatment. If, however, it takes a long time for the PSA to go, so if it goes from 100 down to 90, and then from 90 to 80 every 3 months, that's a very slow drop, and that's worrisome. If it goes from 100 down to 10, and then the next one goes to zero after 3 months, that's a very good rapid drop, which usually means the cancer is very sensitive to the hormone treatment, and it'll be a long while before the cancer wakes up. This is something that I think people, we take for granted. Again, prostate cancer is unique as compared to most other cancers. There's this blood test, the PSA test, that is just so sensitive that can tell us a lot of what's going on. Most other cancers, including breast cancer, there's no blood test that can be that precise. And in most other cancers, patients have to have scans all the time. Every 3 months, every 6 months, they have to have a battery of scans. And for prostate cancer, if the PSA is zero, we normally don't need to do any scans. So that's a good thing.
In your practice, what are the biggest changes you've seen in the last 25 years? I mean, 25 years ago, what was the survival rate or the story of a man with advanced prostate cancer compared to today in 2020?
Well, I mean, probably the last 15 years, there's been a major shift. So 25 years ago, if a man had prostate cancer that had spread to the bones, for example, that person's life expectancy was probably 3 years or less. And all we did was use traditional hormonal treatment. And then we knew there was nothing else. And we believed back then that there won't be any new treatments to improve the survival for prostate cancer, because we thought prostate cancer, since usually it's such a slow growing cancer, that the traditional treatments like chemotherapy and other treatments are not going to work. And that was the belief many years ago. Last 15 years, we realized with proper research, proper studies, that that's not the case. And so we now know chemotherapy works and can work multiple times. Several types of chemotherapy can work. What we thought was that the hormone therapy that we were delivering with the injections was the most we can get out of hormone therapy. We realized that no, that's not true. By adding these new drugs, which are still forms of hormone treatment, we can actually improve even more the benefit from hormone treatment. We've learned that if we can just understand more each person's cancer, the genetics of each person's cancer, we can target treatments with newer molecules, like we talked about olaparib, for example, in the last year. And the whole field of imaging. 25 years ago, we used to do a scan. The quality of the scans were not great. Back then, we thought they were fantastic and we were mesmerized. Well, now if I showed someone a scan from 25 years ago, people would be surprised as how do we take care of people with such poor imaging 25 years ago. Nowadays, the imaging is just so much more precise. So we know so much more of what's going on. The one thing that hasn't changed in 25 years is the PSA test. The PSA test back then and now behaves the same way. It's done the same way, and it still has the same reliability as it did 25 years ago. So today, a man that presents with prostate cancer that has spread, that has not been treated yet, there's many, many more years of life than in the past when it used to be down to 3 years or less. Now we're beyond, we're up into 7, 8, 9, 10 years of survival. For a cancer that has spread, this is quite remarkable compared to many other cancers that when it has spread, their survival is still quite poor.
You're absolutely right, Dr. Aprikian. If we go back to the new generation hormone therapy, if one is not necessarily working, I know you said they're from the same family, does that mean that you cannot interchange them? Let's say if for one type you have terrible side effects, or you're not feeling well at all, can we try another agent?
So, so it depends on what the reason is. If one particular drug is being used and it's not working against the cancer, trying another drug is not going to work. So switching from one to another, because the drug isn't working, the second drug is usually not going to work. And in fact, we're not supposed to do that, and we're supposed to move on to some newer treatment that is different than hormone treatment, so we don't waste time. In the setting where the drug is working, but the side effects are very bad, a particular side effect that is, let's say, unique to one of the drugs, there a case can be made to switch to a different drug. Although what we normally do in such setting is we cut the dose of the original drug, or even give a little bit of break of the original drug and monitor the PSA count before switching, for example. But in rare instances, yes, we can switch from one to another in the case where the drug is working and the side effects are quite unique to a particular drug.
Can we lower the dose for chemotherapy in the same way that we can do that when the side effects are a little bit too hard for the patient?
So the chemotherapy is usually delivered, the dosage for chemotherapy is based on the patient's weight. So there's a specific menu that has to be followed, and also their health condition. So the oncologist usually chooses the dosage based on a variety of parameters. Usually after the first 1 or 2, 3 doses, the patient tolerates well. It's usually after the 3rd dose of the chemotherapy that the side effects start to be a bit more cumulative. And sometimes instead of cutting the dose, we give the patient a break. We do what's called a chemo holiday. We stop for a while, let the patient recover, and then restart again. The theory is that for chemotherapy, when you decrease the dose, you can make things worse if you don't give the right. It's like antibiotics that have to be given at a certain dosage. If you give a low dose, the bugs actually learn and they become resistant. So if we're going to give the chemo, we want to give it at the right dose. And if the patient can tolerate, we'd rather give a break.
Okay, that's great. I saw a question in here from Dr. Michel Tremblay. His question is, in many cancers, a genetic profiling of the tumor is made as a general feature. What is the status of the genetic analysis for prostate cancer at the MUHC, and how does it affect treatment?
So at the moment, we don't do routine profiling of the primary cancers because from a treatment point of view, there's no action yet. So it's not part of standard of care. There are research protocols where people try to profile individual cancers and then to identify particular genetic mutations that perhaps later can be useful in a particular patient. What we hope to be doing soon, because of the availability of drugs like olaparib, for example, is to have patients have their tumors sequenced or profiled at the beginning and then during their trajectory as the cancer progresses. But also some people are actually born with some of these mutations. They have what we call germline mutations, meaning they carry in their bloodstream, in their genetic makeup, they have a mutation in one of these particular genes, so that later in life, when they develop a cancer, then a drug like olaparib can be quite useful. So the future is that every person who has a particular type of cancer, not just prostate cancer, will have their blood DNA sequenced or profiled to see if they carry any of these susceptibility genes in case their cancers one day become advanced and then drugs can be used to target. For prostate cancer, we're not at the same level as, for example, other cancers, where it's almost routine, where samples of their tumors are actually sent to a laboratory looking for certain types of genetic mutations because there's certain drugs available. At the moment, we're not there for prostate cancer, but we're not far.
This is very, very interesting. I have two last questions before we conclude. One of them is, when are we going to have a liquid biopsy? So we no longer have to go through tissue biopsy?
So that's also a quite excellent question. There are pros and cons to liquid biopsy. The pro is we just do a blood test. And the hope is that the cancer cells that are in the bloodstream are representative of the cancers that are maybe hiding in the bones or in the liver. And if that's the case, then we can just rely on the blood biopsy or liquid biopsy to make decisions on treatment. The con is that if the cells that are in the circulation, which are the ones that we can characterize in the bloodstream, are different than the ones that are in the liver or in the bones, then the liquid biopsy would not be very representative of what's going on in the person's organs. And it's the ones in the organs that are the ones that are causing the trouble. So most men that die from cancer is because there's cancer in the bones, in the liver. It's not from the cells that are in the circulation. So, however, having said that, the promise is that by looking at what's happening in the bloodstream over time, we would have a much better idea of the types of cancer cells and what are the important elements that make them thrive, which would be an easier way than doing needle sticks into the liver or into the bone. This has started for, again, other cancers, and therefore we believe it will be just as important for prostate cancer.
This is great. All right, well, as we close this webinar, Dr. Aprikian, what would be your advice for men, the participants who are listening to you and those who will be looking at this webinar because they have advanced prostate cancer, they have a recurrence, or, what is the advice you would give to these men?
Well, I guess a few things. One is don't be afraid to ask questions. If you don't understand what's being explained to you, ask. Have family members listen also, so that because it can be complicated. So make sure there's multiple people that are listening and that are advising, that are helping you. So that's number one. Number two, if you're not sure, you can always ask for a second opinion with respect to any new treatments that may be available somewhere else. Three is, you should have hope. Prostate cancer, as I said in the past, we often just did hormone treatment and that was it. Nowadays, we have 4 or 5 layers of things that can be done, each one with its delay in the disease progressing. So there's hope that having an advanced prostate cancer diagnosis is not an immediate demise. So there's good news there. And of course, you can help out others by participating in support groups or help out an organization like Procure, buy a bow tie, get people to buy a bow tie. All of these things can be quite helpful.
This is great. All right. Well, we're coming to the end of this webinar. So people, please don't leave right away. Your opinion matters. And when you leave this webcast, you will be asked to complete a survey. So just click on the button that will appear on your screen. That's the first thing. Second thing, outstanding questions will be sent and answered individually by our nurses. I mean, if we have a phone number, you will receive a call directly as of tomorrow. Please join us for our next webinar. It will be on, it's completely different. It will be on demystifying prostatitis, November 24th, with Dr. Carlos Marois, urologist at Les Cliniques Carlos Marois. Please note this webinar will be in French. And then once again, a huge thank you, Dr. Aprikian, for your precious, precious time. It's extremely appreciated. And I wish all of you a great evening. Thank you so much, Dr. Aprikian. Really, really appreciated your time. That was great. That was absolutely great.
Good night, everyone. Good luck.
Good night, everyone. Have a great evening. Bye-bye.